Assalamu alaikum.
Salam Latte.
Good morning. How are you?
Hi.
All are okay?
Okay, doctor.
Okay. You are welcome for this lesson about procedures, which is a very, very important for your career. Let us start by al-Kitab. Okay, who will be the first to present today? Is it Musliha?
Yes,
Muslihana?
doctor.
Okay.
Yes, doctor.
Go ahead, Muslihana.
Okay. Bismillahirrahmanirrahim. Assalamualaikum everyone. My name is Muslihana binti Muzakir with metric number 1519824. Okay. So what I'll presenting today is the growth chart, BP measurement, and also the growth chart, head circumference, and also BP measurement. Okay, next slide. Okay, so in growth chart, it is important for growth monitoring, of course, where every vaccination visit in children, there'll be growth monitoring by the staff nurse and the physician in charge. And then screening, it is screening for dietary or nutritional status of the children. And by applying the knowledge of growth chart, we can actually empower the parents regarding the children's health in health promotions. So basically, it's primary prevention. Okay. So for growth chart, basically we have two ways of reading the growth chart. So first is by percentile and the second is by Z-score. So growth chart of a children is monitored according to the weight and also the height of the children. So for let us go to the chart first. So later we'll go back to this table. Next slide. Okay. So for each weight and height, they have different chart chart for boys and also for girls, and it's differ according to age. So in based on pediatric protocol, the latest edition, so it's divided into the weight for age for boys from from birth to 2 years old, and then from 2 to 5 years old. Same goes to the children. And then this, however, I'm only managed to get the chart from WHO. So from WHO, it starts from the birth to the to 5 years old. So from the chart, the x-axis is the years of the children, and then the y-axis is the weight of the children, since we want to know about the weight. So we have, as I mentioned before, we have percentile and also the Z-score. So for boys, we use blue color, and then for girls, we use pink color. So can we go back to the previous slide? So uh, from the growth, so we usually use percentile. So if it's within 5 to 95, it's considered normal. And then for Z score, we have more than 3 more than 2, more than 1, 0, -1, -2, and -3. So as we plot the graph, so we can know if that patient is at which score. So from that we know that the children may have a normal weight or abnormal or underweight. So if it's less than 1, it's considered normal. When it's 0 to more than 2, we may use BMI. And then if it's more than 3, it's considered abnormal or obese. Then if it's less than 2, it's considered underweight. So that is what we can conclude from the weight, the growth chart based on weight. So okay, next slide. Next, this is the previous. So as I mentioned, pink is for girl. However, the concept is almost the same. But the growth chart, however, growth chart is we use it as when we plot the graph, it's actually the cross sections, meaning the type is cross sections. We just know that the current conditions. So what we can do is if we plot it frequently, then we frequently meaning with frequent visit, we can uh, really monitor the growth progressions of the children. Okay, so next slide. Okay, this is the slides for height, and also this is the slide for height for boys and also girls. The concept of is almost similar. So okay, next is head circumference. So for head circumference is usually it's really important to detect the head abnormalities such as microcephaly and macrocephaly and the progressions of the problem. So the causes of we have the causes of microcephaly and also macrocephaly. So the causes we can actually divide into three parts, which is the antenatal, during the delivery, and also postnatal. Postnatal. So the causes might due to congenital infections, during the pregnancy, inborn error, metabolism, birth asphyxia during the delivery, and neonatal sepsis. Can also cause the patient to have microcephaly and any central nervous systems infections such as encephalitis or meningitis during the uh, infant period. And the cause of macrocephaly could be because of hydrocephalus. It could be because of congenital malformations, and then achondroplasia due to the thickening of the bone that cause the patient to have like a relative increase in the head size, and then subdural hematoma and intracranial tumor and fragile X syndrome can also have macrocephaly. Next slide, please.
Sorry,
So,
sorry, very
it's
important for the previous slide, please.
okay.
The familial, there is some familial micro or macrocephaly. It is one of the most important. That's why we must measure both mother and father head circumference, because there is familial issue to be included. Yeah, it may be you make pathological causes. For non-pathological, it may be familial, like my father or like my mother. It is not a disease. So just include it, okay?
All right.
Okay, thank you.
So next, so for head circumference, same with the weight and also the height. So we have the percentile and also Z score. So usually, the normal baby will born with the head circumference about 35 centimeter. So um, okay, so we can during uh, since the growth of the the head circumference well the chart is slightly different because during the um, early early months early infancy, so we have like a very steep curve because the head is relatively bigger than the body of the baby, uh, and the rate of uh, its the development is faster during this period. Okay, and okay, next, next. Okay, this is for girls. Next. Okay. I forgot to put the how. So basically, how we can measure the head circumference is we take um by using the tape, we take uh the biggest diameter, the biggest and central diameter. So it's not that high above the forehead. It's about uh, just above the just above the ears, just above the ears, around the forehead. But it's also depends on the shape of the head. But however, the key is the biggest diameter, the biggest central diameter of the head. Okay. Um, in there is a video in YouTube, but I'm unable to provide. Maybe we can watch it in YouTube.
Sorry,
So,
again to confirm, you are measuring it how many times?
pardon?
You are measuring the head circumference for how many times?
For how many times?
Mhm.
Um,
You must
for get the average.
no. You are
Okay.
measuring it 3 times and got the largest one.
Oh. Um,
Okay, because head circumference is not like the other to get the average. Usually, you need the true circumference, which will come the biggest one.
the biggest one.
So you measure it 3 times and you retrieve the biggest reading.
Okay.
All my comment must be re-added in your presentation, please. Okay.
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 So next is BP measurement. So BP measurements, the importance is of course to monitor one of the most important vital sign, which is blood pressure, and to detect any problems of hypertension or even hypotension. And then we need to know that in pediatrics, the blood pressure it's differ according to the gender, age, and also height. And okay, so okay, how to take the blood pressure for children? So first of all, of course, we need to expose the patient properly and positions the patient according to our target. If we want it's in lying position, and then we do it by lying, and then if it's sitting position, so we take it when the patient is sit. And we need to make sure that both patients and the physicians in a comfortable position. And then since we measure the blood pressure of pediatrics, so actually we have different cuff, different size of cuff. So we have for neonates, for infant, and for children. And for adults, we have also different size. If the adult is in normal size or obese. So this appropriate cuff is very important to make sure that the blood pressure, the value that we get is uh, accurate. And then, okay, so before we can take the blood pressure, so we palpate the artery first, the brachial artery, then properly positions the cuff at the uh, about 2 inch above the antecubital fossa, and then use the palpation to estimate the systolic blood pressure. And then while uh, uh, for radial pulse, if let's say that the brachial we are unable to do at the brachial, so we do at the forearm. Okay, yeah. Supposedly we do at the arm. Okay. So, okay. So inflate the cuff until the pulse disappear. Release the pressure until the pulse return, and notes the reading on the sphygmomanometer. So, this is our systolic blood pressure. And then if we inflate above, and then we slowly release the pressure, and until the until the pulse is not heard, then that is the diastolic blood pressure. Then we record and plot on the BP chart. So for children, we have specific BP chart. So next slide. So this is the blood pressure level for boys by age and height percentile. So usually we will have this blood pressure chart in the ward, and um, usually the chart is
مرجع ده منين يا حمد؟ اوكي.
Usually the chart will have like few pages of slide. So first we have to measure, and then by comparing the systolic blood pressure and diastolic, and read the BP percentile for different. So let's say if a patient is 2 years old, and then we have read the BP, so the BP is like this, for example, and then the systolic blood pressure, for example, 100. Then we look whether the systolic blood pressure is in which centile, which percentile. And then also for diastolic, let's say it's 88, so look which centile is 88 is in, like that. Okay, so it's different from boys and also girls, but there is not it's not like growth chart where we can see the different colors, but the chart will be full of numbers. So we need to like really carefully look for the values. So the suggestions is by using 30 centimeter 20 centimeter ruler. Okay, so okay, next. This is the girl. Next. So this my reference. Thank you. Any question? No questions. Thank you.
Okay.
Yes.
Okay, so now let's proceed with me. I'm Hania Shatira binti Ahmad Fauzi. I will share about the venipuncture. Can you guys hear me?
Yes.
Okay. Okay.
Yes.
Okay. So this is my content: the indication, contraindication, site, equipment, procedure, and also the complication. Next. Okay. So venipuncture is the procedure of entering a vein with a needle and is undertaken to obtain a blood sample for diagnostic purpose using hematological, biochemical, and also bacteriological analysis. So it also to monitor level of the blood component. So why is it important for us to know? Not only for the diagnostic purpose and also for the management, is because venipuncture is one of the most common procedure and can be a traumatic event for the child and also for the family. So venipuncture should only be ordered when necessary. Next. So there is no absolute contraindication in venipuncture, but it should be avoided in arm that is injured. Could be there is inflamed fracture, or there is burn. Could be infected arm or edematous arm. So it also need to be avoided in a previous venipuncture site or any heart sclerosis vein. Next.
Can we put the expression is contraindicated or like that, because
I should change.
If it is infected, okay, there must be relative contraindication. I can't, because I will do septicemia and bacteremia for the patient.
Oh, okay.
So you can write contraindicated in infection, but if injured and edema, consider it as different weight of that. Okay, avoided it may be understandable, but if there is infection in the place, even if I'm going to do lumbar puncture, it's contraindicated. I will boost the organism inside the body. Okay. Okay, no, not now. Just go to your notes and you can finish.
Okay. Okay, doctor. Okay. Next. Okay, for the site, choosing the correct vein is very important. So when selecting the appropriate site for the venipuncture, it is best practice to begin in the most distal aspect of the vein. So this will allow a further attempt above the selected vein, which is not being impended yet. So when we want to choose the site for the venipuncture, we need to observe for a large superficial full vein in a site that is not inflamed, and then when we palpate the vein, we need to ensure that it is soft and relatively straight and unscarred. So we also need to choose the non-dominant hand. So as you can see from the picture at the left side, we have this median cubital vein, and then we in the antecubital fossa, and then we have this cephalic vein and also basilic vein in the forearm. And then on the right picture, we have metacarpal vein in the dorsal venous network. So the metacarpal vein would be the first choice for neonates and also infant under 2 years old, as other vein may not be accessible due to higher level of subcutaneous fat. And also other than hand, children may also require venipuncture in either the leg or the foot, but these are not very common sight and should only be carried when all other sites are inaccessible. Okay, so next. Okay, this is the equipment. So you can use a wing butterfly needle, 23 gauge, or open-ended needle, 22 to gauge in the blue color. And then why wing butterfly? Because it can provide easier access and also movement in the vein. And then we have shrink with barrel volume. So depend on the collection needed and also the age of the child, could be 1 to 5 mil, or for older children could be 10 mil. Then we have sterile gauze, alcohol swab, medical tap, tourniquet, and also require blood tube and also non-sterile glove. But tourniquet is for the older children, for neonates or infant. As you can see from our clinical, they used to hold, the doctor used to hold their wrist by flexing their wrist. Okay. Next. Okay, so for procedure, let's start with the peri-procedural. So first, we need to educate the patient, and also the parent. So we need to explain the procedure and allow time for question. And then important to for us to have informed consent from the child and also from the parent prior to procedure. And then we gather all the equipment, and then for patient preparation. For the patient safety, it is important for us to make sure the patient identification is correct prior to the procedure. And then for documentation, as we know, every time we do the venipuncture, there is a form that will accompany the blood sample to be submitted to the laboratory. So we need to make sure that all the form is correctly being filled. And then for positioning, make sure the patient is comfortable. The parents can also play a role and could be the mode of support, or we can give them distraction during the venipuncture procedure. Make sure the light is adequate. And then there is actually a holding technique. As you can see, when they do the procedure, they are like holding the child. So there's actually a holding technique for that. And then if the vein is not prominent, we can use gravity by lowering the limb or open and close the fist. And we can rub the area lightly, but never hit the vein because it can be painful for the child. And then for topical anesthetic agent, we have Amitop gel, amla cream, or ethyl chloride spray. So this can produce numbness of the skin, and it can reduce the pain experience during the venipuncture site. But in infant, we should be supervised because we afraid of accidental ingestion. Next. Okay, so for this step, it is better actually to look at the video. So I've put a video, but it's quite lengthy because it combines several techniques to do the venipuncture. So I'm sure you guys are very familiar with the venipuncture step. And next. Next. Okay, so this is the video. I mean, can you play at 3:40?
Way to draw blood. Draw up the amount of blood you need. Release the tourniquet. Remove the needle and cover the site with a cotton ball.
Okay.
Fill the labeled tube and safely dispose of the needle.
Then, stop. Okay, as you can see, that's a quick video that we showed just now. Okay, next is the complications. So there is a peri-procedural and also post-procedural complication that may happen in the venipuncture procedure. So it is important for us to be aware of the complication, especially in non-verbal kids or younger children. So pain, we can minimize the pain by the anesthetic cream. And then if there is failure access to the vein, it could be due to the collapse of the vein, could be due to incorrect position or incorrect angle of the penetration. And then for cessation of the blood flow, it could be due to vein collapse again. And then venospasm could be penetration of the posterior wall of the vein. And then we need important for us to observe the developing of hematoma, because when there is hematoma, it is necessary for us to remove the the needle. And then could be there is accidental arterial punctures. So it is important for us to palpate the vein carefully before attempting to insert the needle to ensure that there is no palpable pulse in the vessel. And then thrombophlebitis can be caused by thrombus formation with subsequent inflammation, or there is infection, or could be both. And then the last one is peripheral nerve injury. This is rare, but it could possibly happen because of the site of the nerve.
Okay. Sorry, it is very important to consider the thrombophlebitis is one of the most common complication which we see, and all the units now for the issue of infection control, we have the census of any, we must do like incident report for any thrombophlebitis. As you know, in pediatrics, it is very dangerous, especially now we have the same which you are doing the peripheral line, we can do it BICC, means peripherally inserted central line. It means if the infection, it will go directly to the blood. So early detection of thrombophlebitis and the trial to prevent it is one of our gold standard practice, especially in critical situation.
Okay. Thank you, Dr.
So you need to put like simple comment about how the thrombophlebitis appear.
Oh, okay.
The vein will be red and you can feel some edema in the course,
yes.
change in the color. Really, because it is very, very traumatic to have like small baby in unit or childhood, and after that came out with bacteremia and with a local infection. Okay. Of course, extravasation also is one of the common. You are doing only venous puncture. Okay, enough. But extravasation will be with the next presenter, which also can cause a lot of problems. Sometimes it can cause gangrene if you have concentrated glucose or like that. Okay, that's fine. So.
Okay, next. Okay, so now we move to intravenous peripheral cannulation. Okay, so this again the content. Next. Okay, so the intravenous peripheral cannulation, defined as a hollow plastic tube used for accessing the vascular system. So the venous access can allow the sampling of blood as well as administration of fluid, medication, parenteral nutrition, chemotherapy, and also blood product. Next. For the contraindication, okay, I think this also I need to change. For the infection could be the contraindication, and for avoided in injured and also edema extremity. Okay, next. Okay, so for the site, as you can see, is same as the venipuncture. But also here you can see other like the foot and also the scalp vein. Again, it is not common to do IV cannulation at this site. However, we can do at this site if other vein is not accessible. Okay. Next is the equipment. So the equipment, we have the IV needles. So it more same like the venipuncture, but the difference is we have the saline. We have the saline solution, the NaCl solution, and also the use of cannula. Next. Okay, so this is the IV cannula size and color. As you can see, there are several colors. So for the children, we usually use 22 gauge, which is blue in color. And for the neonates, you can use 24 or 26 gauge. So the important to know that is that in the size, the IV needle size, IV needles are sized by the gauge, and the smaller the gauge number, the bigger the needle will be. So that's why we use the 22 gauge and above for the children and also the neonates. And then next, so the procedure is more less same as the venipuncture. So we have to educate the patient, having the consent, gather the equipment, and then patient preparation. Again, we need to identify the patient, fill the form, then the position of the patient, and then we can also have topical anesthetic agent to reduce the pain. Okay, so next, okay, the step it is same like the venipuncture, but is that different? The difference is that we need to flashback, we need to flush. We need to flush the needle in the IV cannulation by the saline solution. Next, okay. So this is the video. You can watch it later. Okay, next. So this is the complication. As you can see, it could be like the venipuncture when there is peri-procedural and also post-procedural complication. But I will talk I will talk only a bit of it that could be different from the venipuncture. So first is number 5, the difficulty in flushing after the catheter was placed in a vein. This cause might be from the catheter tip position against the venous wall or a valve. Could be there is a blood clot or piercing of the venous wall. And also again, we need to observe any hematoma. And then others could be compartment syndrome. So compartment syndrome, so in IV cannulation, there will be continuous infusion of solution into the venous access device. So there could be extravasation into the surrounding tissue, and this could lead to compartment syndrome. So we need to make sure to monitor the site while transfusion is taking place, and we need to use extra caution in patients who are unable to communicate the pain, also discomfort. And also the last one is skin and soft tissue necrosis. So for this, when we infuse something into the venous access, such as vesicant or irritant solution, it could cause severe soft tissue necrosis, which can extravasate outside of the vein and go to the surrounding tissue. So that can cause skin or soft tissue necrosis.
Yes, thank you. Just to come back for this slide. Number 1, the pain. How can we decrease the pain? You must.
So for the pain, as I said before, it is like the venipuncture. We can minimize the pain by application of the anesthetic cream. Like 30 minutes before insertion of the device, we can apply the anesthetic cream.
For neonates?
For neonates, actually I'm not so sure for neonates, because it said that we need to supervise if it is neonate, because we're afraid of accidental ingestion in neonates. So I'm not sure about how to reduce the pain in the neonates.
Sometimes to give him just dextrose 2 ml per mouse, it will decrease the sensation of pain, and it will help us in the procedure, especially if you don't have this topical analgesia. The other thing which is most important for the fluids which mustn't be given in the peripheral vein. Okay, any dextrose, if dextrose more 12.5 and more, cannot give into the peripheral vein, because it will the vein will be already dislodged very rapidly, and it will cause extravasation, which can cause sloughing, and sometimes it can cause even gangrene of that area. So also if you are applying like TPN, total parenteral nutrition, anything more than 1000 millimole, the osmolarity cannot also give into the peripheral. That's why we are speaking now about a central line or peripherally inserted central line. Okay, you can start from a very peripheral line, but you will connect it until it came to the central vein, okay, which is very, very applicable. The third thing, during the insertion, we need to get some points. If you have the vein like that, some are going to puncture directly. It is better to come slightly half centimeter or like that before it, so you enter the skin and settle there for a while, and then you try to puncture the vein. Some are going to get it directly, okay? The same of puncture the vein, which also you must put in your mind, is arterial puncture. Okay. No, this is standard now. If you have one baby and you need to do in critical situation and you need to do arterial blood gas, it is the same, more prominent. If you put your hand, you can palpate the artery very simply, okay? That's why you must get an idea about that, especially in ICU situation, okay? It is the same idea, but how to fix it, how to puncture the artery and be very sensitive to check the other artery. If you are using the radial, you must check if the ulnar is working or not. And you are going by a certain degree until you get blood and there insert the cannula, and it will be in situ, may stay with you for a few days. Anytime you need blood or need sample for blood gas, it is available, okay? It is the same procedure, but with some precautions, because puncture of the artery, as I speak before, can be cause a lot of trauma if you are not keen. Thank you. Good, Hani.
Thank you, Doctor.
But I have a question. How many times should we attempt this sample if we, especially in housemen, where we tend to fail in neonates and also small children? How many times should we attempt to take blood taking before we stop?
Yes. It is not related to your houseman, related to your or life. Really, if you are, we must be very professional. Sometimes you are a very good professional one, but you cannot pick the vein for twice time. You must be very irritable and you must pick it because it will cause more trauma. And at the end, you will call for help. After you tried, I remember someone who is a very panic to be ashamed that he cannot go the vein. He pricked the baby on the 4 limbs. I don't know how many bricks in the same limb. So the one come after you now, he became obstructed. A good example which I saw while I'm starting my life is a very big name. He tried twice to insert a line for a very critical or small child, and he said, sorry, it is not my day. Frankly, it is not shameful. Anyone can try. I tried twice, really. I didn't want to cause more trauma. So it was one of us who's just recently graduated once said, can I try, prof? Okay, I go ahead. And he got it. And we tell him, thank you. We didn't say to the prof, you are bad because you didn't know. As usual, put the benefit of the patient on the top. If you feel you failed twice and you are very confident to get another one, because at certain points, the babies are very sharpy and obese and the vein is not so easy to be picked. At the time, it is better to ask for help. But don't leave baby in critical situation to say that I'm asking for help. Inshallah, it will come afternoon. Especially if the baby has vomiting, diarrhea, and like that. So you are a wise man, not a doctor. You are wise because you are in charge for keeping either the life or the quality of life. Both can affected by mortality and morbidity. Okay.
Yeah, doctor.
Okay. May I start, Doctor?
Yes.
Okay. Assalamualaikum. So I am Amira. So we would discuss about the blood culture sampling. Okay, next slide. Okay, so basically blood culture.
We cannot see you. Your name is
Amira.
Amira. Okay. Okay.
Amira.
Okay, Amira.
Okay. Blood culture is an inoculation of blood sample from patient suspected to have a bloodstream infection in a specialized blood culture bottle that contain broth media that supports optimal growth of the bacteria. So the aim of blood culture is we would like to confirm the diagnosis of infectious agent, and we would like to identify the microorganism and optimize the antimicrobial therapy. So what happened when we take the blood culture is that we would inoculate the bacteria in the broth and send it to the lab. So when arrive in lab, they would incubate this incubation. During this incubation, they would centrifuge the bacteria, and once the incubator gives signal there is positive growth, then they would proceed with the gram staining. If you remember in basic science, we have done gram staining, right? So if the gram stain is positive, they would then either negative or positive, they would then look at the microorganism under the microscope to identify the morphology, and after that they would subculture it and send for sensitivity testing for antibiotic. Okay, so this is basically the pathway of the blood culture. The incubation, what they would do is that they would incubate this culture until about 5 to 7 days because it can be that during this period, the blood culture can be positive or negative, depending on the time of depending on the blood, the bacterial load in the blood. So they would just incubate until 5 to 7 days. Okay. And then they declare that there is no growth or not. Okay, next. Next slide. So if you can see the diagram just now, okay, there is 2 bottles, which is the aerobic bottle and the anaerobic bottle for adult, which is requiring 8 to 10 mils per bottle, and then for pediatric it will be pink cap because commonly
Your voice is
infection.
interrupted. Your voice is interrupted.
Yes.
Can you adjust your microphone?
Can I close the video? Close internet connection is not stable.
Okay, do your best. Yeah. Now it's clear.
Oh, sorry. Yeah. Sorry. Can you hear me?
Yes, yes, it's clear now.
I think I got unstable connection. So can I stop the video?
No, you can stop the video. Okay,
Okay.
we can see it after that.
Okay. Okay. Next slide. Until what part did I stop just now? Only about the pediatric bottle, right? Okay, it's okay. So for blood culture, it is the ultimate indication is when you suspect there is infection, or either it is bacteremia or fungemia. So what is bacteremia in the box? It is the presence of bacteria in the blood, which can be transient bacteremia, intermittent or continuous. So for fungemia is the presence of fungi in the blood. we have to take note here the difference between bacteremia and septicemia. So septicemia is a clinical syndrome of fever, chills, malaise, tachycardia, etc. sepsis, when circulating bacteria in the blood is multiplied at a rate that exceeds the removal of phagocytosis. So bacteremia, septicemia is a bacteremia, but some bacteremia is because bacterial load still can be adapted by our system. Okay, and there is no general culture when patients have signs symptoms sepsis, fever, or leukocytosis, or patient is suspected to have endocarditis, or there is severe infection like meningitis, pneumonia, pyelonephritis, septic arthritis, or if there is or we would like to start antibiotic therapy for immunocompromised patient or elderly. Okay. Next. Okay. So the common pathogens that can be found in bacterial bloodstream infection is, for infants less than 3 months, would be Escherichia coli, Group B Streptococcus or Streptococcus agalacti, or Staphylococcus aureus. If in children more than children, the rate of BSI is otherwise drop rapidly after the first few months of life. If affected, the common pathogen would be Staphylococcus aureus, Streptococcus pneumoniae due to community acquired pneumonia, or it can be Neisseria meningitidis in adolescent. And to take note here that in addition, if immunocompromised patient, it could be Pseudomonas aeruginosa or Candida species. Like back to the in past, in 1979, the common organism would be Haemophilus influenzae, Streptococcus pneumoniae. But however, due to the vaccination and immunization, these Haemophilus influenzae are rare in bloodstream infection. Okay. So, what are the factors that affect the recovery of the pathogen? Meaning, the blood culture is positive and the antibiotic is effective. The factors would be, number one, blood volume, which is if the blood volume is adequate, the probability of recovering a pathogen from the blood culture is increases. Okay, so we have to, and the blood volume really affect the blood culture positivity, which is we have to take an adequate amount for adult, at least 10 mils per bottle. Okay, so 20 mils per culture. And then for pediatrics, recommended volume will be based on the weight of the patient. As we have, as we noted that the total blood volume in babies is different, is smaller than the total blood volume in adult, right? So at least 1 to 3 mils per bottle. And there is also another recommendation, which is 1 mils per year of life. Or but the best one recommended is based on the weight of the patient. Like in the diagram that I provided, this is the recommendation. Like less than 1 kilogram would be recommended volume of blood culture is the maximum 2 mils. Like for if the weight is like adult, like more than 36, then we can collect the blood more than 20 mils, 20 to 30 mils. Okay, so the next factor that affect this positive effectiveness of blood culture is the number of blood culture sets. Because when you take more culture, they increase the probability of detecting bacteremia, because maybe the first set we cannot detect bacteremia, maybe the second set. So the recommended set for adult would be 2-3 sets of culture, because in a single blood culture it lacks the sensitivity and we cannot distinguish between bacteremia and contaminants. But however, in pediatrics, it is found that adequate blood volume, which is more important and yields better result than multiple blood culture sets. Okay, and the last factor would be timing. Classically, they believe that the most appropriate, the most effective time to actually take blood culture is before the onset of fever. However, it is almost impossible for us to anticipate sepsis before the onset of fever. But this is until recent, they did not find any correlation between spike of temperature and sepsis, because even in bacteremia, there are time that bacteremia is normothermia and doesn't show any sepsis signs. So the most important timing is it is found that it is effective blood culture recovery of pathogen prior to antimicrobial therapy. Okay, so but the most important factor here is blood volume. Okay,
unless
yeah,
this is a wise decision. Try to collect the blood culture before starting the antibiotic, but in certain circumstances you may need to go rapidly, like meningococcal meningitis, like that. If you are able to finish it, yes. Sometimes you are working in a periphery clinic like that, and you diagnosed already, so you need to give you need to give the first dose of antibiotic, either ampicillin or penicillin or ceftriaxone, and send the patient directly to the hospital. So this is my point again. We are working in a wise situation, okay? So, also, the amount must be considered. In ICU, are trying to make it 1 ml, but sometimes in very small neonates, his blood already is 500 grams, so his blood only is 40 cc. Is 40 cc, and we are getting all investigation and repeated it, and doing blood gas every 4 to 6 hours, and so sometimes we need to come to the lower established level by practice. So we may need to come out to know how is the unit established for the amount, because it is not wise if I have a child of 5 years, I will got blood culture 10 ml or like that. So this is general guidance I can accept, but you must try it, okay? Emergency situation must be considered. The second one, we must come back for all our practice to the protocol of the unit which you are working through it. If you feel, if you have a good knowledge, you can negotiate to change. Okay. Okay.
Okay. Next slide. Okay, so this proceeding with the procedure of blood culture. Play. Okay, this is from University Malaya Medical Center. Okay. So these are the equipment. Basically, it is the same as venipuncture. Dia ada suara. Okay, boleh tak mute kan? Mute kan je. Okay. Okay, so it is actually basic. The difference is the equipment we have to maintain the aseptic technique, because in blood culture, the important issue is contamination. So okay, and one thing that is important is for you to check the expiry date on the bottle. Aside from, okay, this is the aseptic technique, meaning that we have to perform the hand hygiene, and the next number sikit video. Okay, and okay, we have to assemble the dressing set. As you can see, the dressing set is a sterilized set, and you can see the bottle. I'm sorry, I cannot find the blood culture sampling procedure for pediatric, but basically this is the same, unless that the bottle is the pediatric bottle. Okay, so we have to assemble the sterile set before we perform the venipuncture. Okay. I believe that you have already observed this, right? So okay, it's okay. We can the only okay, tak apalah kot, boleh dah. Stop. Okay. So the only thing that I would like to highlight here is that, okay. Yeah, dah. Next slide. Okay, the only thing that is different is of the performing of the venipuncture can be either from the butterfly, kan, butterfly set tu, needle set, or the syringe and needle itself. So it is actually better to use the butterfly syringe if in taking the blood culture. However, in when using butterfly, we need to transfer the blood into the anaerobic bottle first. Anaerobic bottle first. But since this is pediatric, we can just ignore the step lah, and put it in the one bottle. Okay. So please take note that in number 4, we have to remove the cap from the blood culture bottles and clean the top first, because we want to avoid any contamination. Okay. And I think and the difference is in number 7, we have to transport this inoculated bottle within 2 hours to the laboratory. This is recommended because and also swirling method to avoid coagulation. Next slide. Okay, this is I got this from pathology department of Hospital Ampang. And this is the blood culture bottle that you are familiar with, which is the blue color is the aerobe bottle. The gold cap is the anaerobe, and for pediatric it would be silver cap or pink cap. So what we need to do as a houseman, we have to read the label, make sure that this is the right bottle, and do not put any sticker on the barcode area. So, and this is actually a common sense. You have to identify and confirm that this is the right patient. And for this bottle has anticoagulant, so we have to mix with the swirling method. Okay, next. Okay, so these are basic sciences, which is what is the gram-positive bacteria and gram-negative bacteria. Boleh nampak ke? Oh, it's okay. So you can read this later. But basically, there is gram-positive aerobic and gram-positive anaerobic. There is gram-negative aerobic, gram-negative anaerobic. So if you remember this. Okay, next. Okay, this is like how does the lab or doctors usually think about this blood culture positive is either through bacteremia or contamination. If you get the call, they will usually call you and tell you that this is gram-positive growth. So they would, you can either suspect that this Staphylococcus aureus or coagulative negative, coagulase negative Staphylococci or Streptococcus pneumoniae. But the next thing that you have to think, if it is possible contaminants. So usually the possible contaminants are the skin contaminants. Okay, so like for example in Staphylococcus aureus, it is not usually if possible contaminants. For coagulase negative Staphylococcus, it may be possible contaminants. So and that's bring us to the first question, which is how many number of positive bottles or cultures are positive? If there both 2 out of 2 bottles are positive, then it is high likely that this is true bacteremia. Or if the culture, multiple set of the culture, all comes out positive, then this might be true bacteremia. And also we have to think about the time to positivity. Like I said just now, we have to incubate, right? And if it took longer to actually comes out positive, then it might be contamination, because contamination it has a low load of bacteria compared to bacteremia. Okay, so this is the next one. The next question will be bacterial morphology, like gram-positive rods, or if there is any pseudo hyphae in Candida, And the next will be a question about aerobic or anaerobic growth. Because, for example, if it comes up gram negative and then it is aerobic, then we would think of Pseudomonas, because Pseudomonas is a strict aerobic. Or if it comes, it is gram positive and it comes back with aerobic growth, then it may be Bacillus. But Bacillus is usually contaminants. So that is how we think about it. But usually, okay lah, we start with empirical antibiotic, right? And then we would wait for the lab to actually give us the specific sensitivity and also specific growth after the subculture. So the next use of blood culture is actually because when there's contamination or contaminants, we would induce more harm than good. Maybe we would give unnecessary antibiotic that patient might not need, or maybe we could actually, if we give more unnecessary antibiotic therapy, and then we would increase the length of hospitalization, and there would also increase in the time of the patient with the cannulation. So cannulation, and this is actually giving more harm than good. So have to really identify where does this contamination comes from, like the source, usually the skin contaminants. So it is preferable that the site of the blood sampling should be upper extremities more than lower extremities because of contamination. And the technique itself, like venipuncture, is preferred from a different site than using the same site of the cannulation, or even you should not use the existing IV lines because of possible contamination. Yeah. But I have a question. Okay, when do we take blood culture in existing IV line? Anyone? When do you think that we have to take from the existing IV line or any catheter? When we suspect there is catheter induced sepsis or CRSBI or CAPC, BSI, then we would take from the specific IV line. Okay, so common possible contaminants is enterococci, viridian streptococci, or coagulase negative staphylococci, just now, corynebacterium. And these contaminants would give false positive growth in the culture that were not present in patient's blood, but introduced by skin or by the environment during the blood taking. So the next issue is, of course, multiple blood taking in pediatrics that could risk with transfusion and pain. Okay, so that's all from me. Thank you. Do you have any question?
Sorry, when we need to collect more than one blood culture?
Huh? When we need
to collect more than one blood culture?
When
which situation? Yeah, which situation?
When
infective endocarditis.
Yes, endocarditis, yes.
This is an important example. The same precaution will be applied also for if you are going to collect sample for the CSF. The same precaution, the same maneuver like that. So to doing any culture, you must be very sensitive. Okay, maybe your colleague will speak about that, but this is a general precaution not to contaminate your sample. Okay, that's a good. And a good thing here in Malaysia, you must be familiar with everything. You must start from 0 point, prepare your table, make sterilization for it, prepare your equipment, and do your self-sterilization, and then doing the patient sterilization, and make sure that everything until putting the blood inside the bottle is completely aseptic and no contamination. Otherwise, you will make all the situation in ungood situation. Okay, thank you. This is okay, catheterization. Okay.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Can you hear me? Boleh dengar?
The volume, please.
Macam mana? Macam mana tak dengar? Hello? Oh. Can you hear me?
Yes.
Okay.
Can.
Okay, my name is Nur Fitri Mustafa 1611660, and I will present two topics, which is the catheterization of the ureter and also the nasogastric tube insertion. So we start with the catheterization of the ureter in boys and girls. Okay, so the urethral catheterization, it is used to permit the direct drainage of the urinary bladder for both male and female. The next slide. Okay, so the indication for the urethral catheterization in terms of the diagnostic indication, first is for the collection of the sterile urine specimen, which is for the culture and analysis, especially in children who cannot void the urine in command. And then the other function is to carry out voiding cystourethropy, and then also to monitor the urine output for the post-operative patient and also in the critically ill patient. For the therapeutic indication of the urethral catheterization, first is for decompression in acute urinary retention, and then for intermittent catheterization in neurogenic bladder, and then for bladder irrigation to remove blood and clots, and also for drug administration. Next. Okay, the only absolute contraindication of the urethral catheterization is in the suspected trauma injury to the lower urinary tract. For example, in the pelvic injury where there is a suspected, for example, urethral tear with the signs such as perineal hematoma, blood adenitis, or gross hematuria. And then other relative contraindications such as major anatomical malformation in the recent reconstruction of the urethra or bladder neck, and also allergic to latex, as many of the gloves or the instrument is made from the latex. And then next. Okay, there are two basic types of urethral catheter, which is the straight catheter and also the Foley catheter. Okay, for the straight catheter, just like in the picture, it is a single lumen, soft, made from the polyvinyl chloride. The function of the straight catheter is for the collection of the sterile urine for the diagnostic purposes, and also for the intermittent catheterization in neurogenic bladder. And then for the Foley catheter, just like in the picture, it is a double lumen or triple lumen tube with the expandable balloon at the distal end of the catheter. So it is made up from either latex or silicone. So the function of the Foley catheter, it is usually used when the catheter must be in the bladder, because the function of the balloon is to secure the catheter in the bladder. So in situation like for the close monitoring of urine output, for prevention or relief of an obstruction, for continuous irrigation of the bladder, and in the imaging of the urinary tract where they need to fully filling the bladder, so they use the Foley catheter for better imaging. Next slide. Okay, so these are the recommended size for the catheter. So the size of the catheter is according to the patient's age. So it is measured in the French gauge. So the measurement is actually the external diameter of the catheter according to the size of the urethral diameter. Next slide. Okay, so these are for the procedure for the male and female. The procedure is actually more or less the same, but the difference is in terms of the difficulty due to the anatomical difference between male and female. Okay, first regarding the anatomical difference, in terms of the male, the urethral meatus is easy to locate. And this is difference in terms of female, because in female, the urethral meatus is quite difficult to locate because sometimes it is covered by the vaginal mucosa. But in terms of the male, the urethra is longer, and then it have the curving anatomical at the base of the penis. So due to this curving anatomy, so it causes a certain resistance when you want to insert the CVD. In terms of the female, it is actually easier to insert the CVD because the urethra is short and straight. Okay, so in terms of the procedure in male, first is in terms of the position. So just like in the picture, we place the patient in supine, and then the leg is in the frog leg position. And then we ask assistant to hold the legs firmly so that we can stabilize the pelvic, and also we can expose the full area of the genital. And then this procedure is actually aseptic procedure because one of the complication is due to the iatrogenic infection. So we must prepare the entire genital area by cleansing three times using the standard aseptic. And then we hold the penis in vertical position with the non-dominant hand, and then we gently retract the foreskin. And then we use the dominant hand to wash the urethral meatus 3 times in circular motion. And then we use the lubricating gel placed on the catheter to ease the passage and also to reduce the trauma to the urethra. And then we slowly insert the tip of the catheter into the urethral meatus with the dominant hand, and we advance it using the finger or the forceps. And then because this is the male, so it have this curving anatomical at the base of the penis, just like in the picture below. So what we can do is basically retract gently the penis so that it will reduce the resistance when we want to insert the CBD. And then the sign that we have already reached the bladder is when the urine drain into the container. Okay. Next. Okay, so these are the female. Just like I mentioned just now, it is actually the only difficulty is to locate the urethral meatus, because sometimes the catheter is misplaced into the vagina. If sometimes the catheter is misplaced into the vagina, the recommendation is just leave it there as a landmark and proceed with the second catheter to the right urethral meatus. Okay, so for the procedure in male, just like the same position in a supine, frog leg position, assistant to hold the legs firmly so that expose the genital area, and then aseptic procedure by cleansing the genital area 3 times, and then locate the urethral meatus by separating the labia. And then when we have locate the urethral meatus, we must first wash the meatus 3 times, okay? And then we hold the lubricated catheter, and then sometimes they also use the lidocaine gel as anesthesia. And then hold the lubricated catheter with the finger of the dominant hand, and slowly and gently insert the tip of the catheter into the meatus and advance into the bladder. And then because this is a female, so usually you will not encounter resistance because the urethra is short and straight. Okay, and then the sign that the catheter already inserted into the bladder is when the urine is drained into the container. Okay, next slide. Okay, so these are the complications from the urethral catheterization, such as the trauma leading to gross or microscopic hematuria, and then fistula due to the perforated urethra. And then in the long-term complication, it can causes urethral stricture. And then paraphimosis can also occur due to the failure to replace the foreskin after catheterization. Because in male, before we insert the catheter into the urethral meatus, first we must retract the foreskin. But after that, we must replace back the foreskin, or it can causes this complication, which is the paraphimosis. And then the other complication is iatrogenic infection due to inadequate septic procedure. Okay, that's all for urethral catheterization. Any question? Can I proceed with nasogastric tube? Okay, regarding the nasogastric tube insertion, okay, this nasogastric tube, it is a fine bore tube, usually made from the polyvinyl chloride, from the polyurethane, or from the silicone. So the name is nasogastric. So it is inserted from the nose into gastric, into the stomach. Okay, so this nasogastric tube, it is the most common route for enteral feeding in children who cannot use the oral route, usually either because of the gastrointestinal disorder, or because of the neuromuscular disorder, or because of the metabolic disorder. So this is the most common enteral feeding alternative route, because it is easy to use, it is minimally invasive, and parents can be trained to do nasogastric tube insertion at home. Okay, and then common indication, it is used to meet patients' nutritional needs, and then to administer medication for rehydration and for the decompression of the stomach in the stomach distension. Okay, next slide. Okay, this is a further specific indication. For the diagnostic indication for nasogastric tube, it is used for evaluation of the upper gastrointestinal bleeding. It is also used for the identification of the esophagus and stomach on the chest X-ray. For the therapeutic indication, it is used to aspirate the gastric fluid content, to administer radiographic contrast to the GI tract, to administer also the medication for the gastric decompression, to relieve the symptom and bowel rise in the small bowel obstruction, and then for the feeding and also for the bowel irrigation. Okay, next slide. Okay, these are the contraindication. The only absolute contraindication is The absolute contraindication is in the recent nasal surgery, and also in the suspected base of skull fracture, because there is risk for intracranial insertion. Okay, and then the other contraindication, such as in the suspected esophageal varices, because it can increase the risk for variceal bleeding, and also in the bleeding disorder, such as coagulation disorder. But sometimes if the nasogastric tube is needed to be inserted in risky patient, for example, in patient with absence of the gag reflex, so we need a consultation with the specialist to perform this nasogastric tube insertion. And in risky patient, we might need to insert the nasogastric tube under direct visualization, or under visualization under the radiographic imaging, or with the help of the anesthetist. Okay, next slide. Okay, so these are the procedure. The first step is to measure the length of the nasogastric tube. So there is 3 points for the nasogastric tube. The first is from the tip of the nose, and then the second point is at the bottom of the earlobe, and then the third point is between the xiphoid process and the umbilical. So these are the length of the nasogastric tube from 1, 2, 3. Okay, and then step 2, next slide. Okay, so the step 2 is to lubricate to lubricate the tube to reduce the trauma and also to ease the passage. And then for the step 3 is to determine which is the best site for insertion, either the left or the right nostril. So in the patient that can answer our question, we can ask him or her in which nostril that there is problem, such as sinusitis. And then in infant, we can gently occlude the nostril so that we can know which nostril with the best airflow, and then we choose the best site for insertion. Okay, and then for step 3, sorry, next slide. Okay, for the step 4, okay, after we choose the best nostril, so we gently insert the nostril and we advance it into the nasopharynx. And then we aim it parallel to the nasal septum and also the superior surface of the hard palate. So when we advance the nasogastric tube gently, actually it will later follow its own passage into the esophagus and the stomach. Okay, so we advance it until the measured length that we measure. Okay, and then for the step 5, because you want to ease the passage into the esophagus, so we ask the patient to swallow, especially in patient that can follow the command. We ask the patient to swallow, and at the same time we advance the nasogastric tube. And then in infant with impact gut reflex, we give them a small sips of water so that they will swallow, and then it will ease the passage of the nasogastric tube. And then for the step 6, this is to prevent the complication, which is the misplacement of the nasogastric tube into the trachea. So we look for the sign of the misplacement, such as gagging and also the respiratory distress. Next slide. Okay, and then to confirm the placement. Okay, so to confirm the placement is important in especially in risky patient. For example, in patient who doesn't have intact gut reflex, and also ideally in the new placement or in the pre-feeding. Okay, in order to confirm the placement, usually they will test the pH by aspirating a small amount of the gastric fluid. So the gastric fluid, the pH will be between pH 1 to pH 4. So if the pH is not if the pH is more than 4, so we might want to consult with the specialist if either we need to confirm it with the medical imaging.
But it may be different if the patient like very neonate pH is maybe slightly higher. Also, if the patient on any anti-emetic or prokinetics or like that, also it can affect any medication. So how we can form other point which we can confirm? Continue? Or is it the only one?
Either testing the pH or by using the medical imaging.
Yeah, but clinically.
Clinically, I'm not sure that.
Anyone can answer.
Isn't it that we use the string and masukkan angin, put air into the NG tube, but and our assistant will use stethoscope to hear the area around the stomach.
Yeah. This is we are doing it for most of the cases. Even the nurses know how to do that. Just a small amount, 1 or 2 ml of air, and push it through the OGT tube or NG tube while auscultating the stomach. Okay, it is one of the recommended one. Okay, because there is some patient who are chronically dependent on Ryle's tube. You cannot ask for every time to do X-ray. Okay, that's why you must have your clinical judgment with also another point. If you feel that usually if you aspirate, it will come to you the gastric secretions, which is known color like that. Okay, so all this is a clue. Yes, stand by for X-ray can be for any intervention, but it is not not needed to be routinely done for every insertion. Okay. And the testing BH sometimes are not available easy. So this clinical point your colleague spoke about is very important. Okay.
Okay. Thank you, Doctor. Okay, next slide. Okay, these are the complications of the nasogastric tube. The complication include the aspiration pneumonia, especially children with absence of the gag reflex, and then pneumothorax due to the misplacement into the trachea, and then intracranial insertion if the child have fracture to the base of the skull, and then it can causes trauma to surrounding tissue, causing rhinitis, esophagitis, and also in long term it can lead to stricture, and also other complications such as esophageal reflux. Okay, next. Okay, I'm done for nasogastric tube. Any question?
You are not specified here. What is the date of your references? Can I see the references again? The references, yeah.
Actually, the reference is from the hospital, but the range of reference is still within 10 years. It is a document from a hospital from overseas.
Don't be. We must be very cautious because our kulliyah offered us a very treasure of sites, and it's free, up to date, and others. So we must go to the recent one, okay? And our goal for any references is not to put references, but is to use it. So we need the recent one, please, okay? Remember that medicine are evolving. It may be after 5 years, you can change a good percentages of your practice. If you ask someone like me on the practice for a long time, everything is changing. Sometimes we are dreaming about something and we found it in our life. Okay. Thank you.
All right. Thank you.
Noor al-Fitri. Correct?
Yes, correct.
Okay. Still, how many presenter? How many?
6 more.
Oh, so you need 6 hours. Okay, just to go for this one. Okay.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So my name is Abdullah Arif bin Abdul Qadir 16111661. So good afternoon to my all friends and doctors. So today I would like to share about long percutaneous line, or also known as peripheral inserted central catheter, PICC. Okay. So next, okay. First, the definition. So the definition for long percutaneous line, it is a long line. A long line is a fine plastic or celastic tube about 10 to 30 centimeter long that is threaded into one of the newborn veins, usually in the upper or lower limbs, to reach a point where the veins become much larger, and then it is usually just outside the heart. Okay. So this is the picture. So usually, as it mentioned there, to reach a point where the veins become much larger. So we prefer superior vena cava or inferior vena cava. Okay, so next. Okay. In general, the routes of central venous can be divided into peripheral inserted central catheter, PICC, femoral veins, external or internal jugular vein, and subclavian vein. However, for my topic today, I will be focusing on PICC or femoral vein. Okay, so what is central venous access? Central venous access is when we put a tube directly into one of the larger vein. So for PICC, we use peripheral. We insert the tube from the peripheral to the larger vein. Okay. But for central venous access, the main goal is to come the tube to the large vein. Okay. So this line must be inserted by trained senior doctor in selected seriously ill pediatric patient. Okay. In hospital, for the past year, housemen can do this procedure under the supervision of the medical officer. However, currently, this procedure only can be done by senior medical officers because it is a little bit difficult. So currently, senior MO only can do it. So generally, for central venous access, we must take the benefit versus the complication of this procedure. So we must think carefully whether we need to put it or not, because the complication of central venous access is, for example, pneumothorax and sometimes life-threatening injuries of the airways, lungs, blood vessels, and heart. So we, as a doctor, again need to judge. We need to put it or not. Okay. So the basic principle to put this line is we use the principle of Seldinger, and then to make it easier to find the vein, it is advisable for us to use ultrasound guided. Okay. Next. Okay. So this is the pro and cons between long percutaneous line versus central line. So you can read after this. However, I would like to mention for the long percutaneous line, as you can see the pros, is the risk of infection is low. Okay. However, for the central line, the tube are easy to insert and remove. Okay. So what I want to say here, in emergency situation, for example, in ICU, after we judge the patient that, okay, we need to put line, so long percutaneous or central, in emergency, we prefer central line because it is easy to insert. Okay. Okay. So next. Okay. So this is the central access. As you can see, femoral lines, the ICC, internal and subclavian. So today I will focusing about femoral and the ICC. Next. Next. So this is the indication for PICC versus contraindication for PICC. So indication to deliver parenteral nutrition, TPN, and then we can why? Because the TPN can irritate the vein. So when we use when we insert through the vein, the TPN, like Dr. mentioned just before, it can make the vein irritate. So we might need to re-put again the drips many times. So to avoid that, we prefer to put PICC for those who need TPN for longer time. Okay. So the other indication is to administration of clinical essential or locally toxic solution. Sometimes we use for take blood for investigation. Contraindication, do not insert through an infected site, do not insert through a burn, do not insert in an injured site. I think it is same like just before. So again, the benefit, it can stay in the place for several weeks. And then we can reduce the number of time of newborn baby need to have drip inserted. Okay, next. So common site for insertion.
To stay for how long? It depends also. Is it now we can use single lumen or double lumen like that? We have everyone has its own upper limit of timing. Okay.
Next. Thank you, Doctor. Okay. So the common site for insertion. Okay. So for upper limb, we can put it in the antecubital fossa or basilic vein. Okay. For lower limb, we can put in the great saphenous vein or femoral vein. So for this, the doctor should take time to identify the most suitable vein for the insertion. And then please be careful because some vein they are close proximity to arteries. So as a doctor, we need to know how to differentiate arteries and vein, because if we put it wrongly, the complication is extravasation of fluid into pleura, peritoneal, pericardia, and can lead to subcutaneous compartment. So it will cause a problem to the baby. Okay, so upper limb and lower limb, which side we prefer? So we prefer cubital fossa vein unless there are contraindication in the area, because in clinical practical, it is more practical and easier to put the tube on that side rather than lower limb. Okay, next. Next. Okay. So basically, this picture just want to show the vein. Okay. So we go to the equipment. So equipment for this procedure, we need sterile set, lidocaine. Lidocaine is a local anesthetic. So next we need a shrink, T-connector, 3-way tap, Seldinger coordination set, needle, get wire, catheter, and sterile dressing. Okay, next. I will show the picture. So this is the picture. Next. So this is the sterile set. Okay, I think all of us already seen this. So lidocaine local anesthetic, shrink, 3 ml shrink, and then T-connector used for administration of the solution into the vein, and then the Seldinger set. Okay, the Seldinger set for the procedure, and then we need needles. So needles, be careful. The bigger the number, the smaller the diameter. Okay. So next, the 3-way tap. Okay. So I go to the procedure. So first, just overall general idea, we need to take the consent, and then we need to inform to the patient, patient parents regarding why we need to do this. They need to understand why we need to do the procedure to the patient. Okay. So after all the general procedures, okay. So first, if the patient is a little bit anxiety, nervous or something like that, we can give analgesic or sedation to make the patient more calm. Okay. After that, we put the patient in the supine position, and then we expose the chosen part of skin insertion. So if we choose the upper limb, so we expose that part. Okay. So as the PITS protocol mentioned, we can use ultrasound guidance to search for the vein. So it makes us more easier to find the vein. Okay. After that, we need to clean the part thoroughly using the iodine and 70% alcohol. And then we infiltrate lidocaine, which is local anesthetic, at the proposed site of skin insertion. Okay, so next we go to the insert. We can insert the saline, fill shrink, and needles 30 degree. I'm sorry, typo, 30 degree to the skin and parallel to the vein. So how can I show it? I'm sorry. Okay. So just imagine this the skin. Okay, so this is the shrink. Inside the shrink, they have the saline, and then at the bottom, the needles. Okay, so we poke the skin to find with the guidance of the ultrasound. We find the vein, and then when we put the vein, we try to find whether there is backflow of fluid into the shrink or not. So if there is flow of the blood into the shrink, so it means that we already in the vein. However, please be careful. If you think there are pulsatile and some things, maybe you are in the wrong vein, which is maybe you are in the artery. So you need to pull it back. Okay. So I assume after we put the needles, we are in the vein. So after that, when there is backflow of blood, stop suction. So you can disconnect the shrink from the needles. So you disconnect the shrink, put needle here. Oh, sorry, you cannot see it. I'm sorry. Okay. Skin. Okay. Assume this needle. Okay. Just put it there. Okay. And then you insert the guide wire into the needle. So guide wire you put it here. Insert the needle. Insert. Okay. Next. So, you put the guide wire. Okay, just put it in guide wire. After you finish put all the guide wire, you can gently pull out the needle. Okay, but please be careful, because if you done it wrongly, it can cause damage to the guide wire, including kinking and fracturing the guide wire. So after the guide wire already in the vein, next we can insert the catheter. Okay, so insert the catheter, insert the catheter until how long we measured about in neonates 10 to 30 centimeter. We just put it. Okay, after that, you check again whether there is blood come from the vein or not. So after all, if you find that it's blood, you can secure the line using the sterile dressing, and then just they're dressing the side of the part. Okay, so how we know that the line already in the large vein? Basically, we do X-ray for the after the procedure, so we can check whether the tube already in the large vein or not. So, and then other than that, beware of local hematoma at injection site, and then always check for distal perfusion fingers and toes before and after procedure. So we want to avoid any infection or something in the vein. Okay, I'm sorry, this procedure a little bit hard to explain by theory. I hope some theory knowledge can help you when you see this procedure in the future. Okay, so next. Okay, this is the Seldinger technique. Okay.
Just a while, yeah, this is Seldinger now is a gold standard for many insertions. Okay. As your colleague said, you are inserting the initial cannula and then you are putting this wire to the right. Okay, but take care about many things. Don't lose the tip of the wire.
Yes.
if it migrates inside the body, you need to do operation to get it.
Yes.
Very, very dangerous. So you must secure the tip in one forceps in your hand. It is very important. Okay. At the same time, during changing now, you would introduce the wire, and then you need sometimes to make a cut, so you can introduce a bigger size BICC. At this point, you mustn't lose the wire, you mustn't lose the cannulas. Okay, you must be very, very cautious about your measurements and using it wisely. That's why it is kept for usually for experienced one. Okay, but it depends on the hospital you are going to work with that, and there is no limitation for how long you can help. You can help, and in front of the other, they can offer you chance for preparation, for insertion, for the initial step like that. Okay. The another thing, remember that it is a bit costly. Sometimes it come to like 1,000. This Seldinger maneuver with BICC. So you must put in your mind the cost for the family and for the situation. Okay. Finished, Abdullah?
Next, the complication. I think
Okay.
the complication still the same like before. Infections. Sometimes the patient can accidentally remove the PICC. So blockage, the line may block due to the blood clot, vein damage from the TPN. Okay, and then damage to the heart is a little bit rare complication. So I think that's all from me.
Another point, if you put your any central line and they came to the inside the heart, I mean you came to the right atrium or past the right atrium to the right ventricle, it can cause arrhythmias. So you are not allowed to go deep inside the heart, okay, to prevent any arrhythmias. Either you are inserting UVC or inserting BICC or even central line, don't go inside the heart, okay. Compartmental, which can, if there is infiltration of the fluid, you can get a collection of the TBN inside the chest, which can cause distress and like that. So it is one of the non-complication. The most important point here, I just read how many words of the Quran and what is the word came in the middle of the Quran. They found it one word in Surah Al-Kahf known as وَلْيَتَلَطَّفْ.
Oh.
This is the middle of Quran. Means وَلْيَتَلَطَّفْ here means be smooth, please. Don't be harsh. Don't be vigorous. Okay. Dealing with any procedure, it needs your professionality, but become soft, please. Don't become very تلطف. تلطف يعني means be smart, be smooth. And remember that for pediatric, you are doing your procedure against resistance. The resistance of panic, number one. So you must try to soothe the babies, try to offer them some toys just to distract them. It is very important. It will be very chaotic if you got 1.5 year or 2 years boy who is very aggressive and he is a bit choppy and there is no clear veins and you are trying to fight with him many times to get a vein or to do any procedure. So please try to be smooth as you can. Today we got about 5. What is the remaining one, please? The remaining titles, because we need to stop now. Okay, what else?
We have chest physiotherapy and sanction, and then application of EEG electrode, and then we have ECG, and then hand washing, and the last one is PPE.
EEG. Very nice picture. Okay, so I will ask, I will try to offer you another session. Let us try, because now we finished already the 2 hours. But you need to share it to the group, okay? You make the correction which I asked you, and I need extra job. Everyone preparing one, he can make small quiz, like few questions, okay, to put it. I will share for the group with you from previous group in the year 5, which we just celebrate with them, alhamdulillah. All of them passed, only one, and a good number got distinction, and it is very good. Hoping inshallah I see you on the top, but start early and be consistent for your future. I may share you also some presentation from the previous groups, okay? So we can conclude at the end. If there is any deficient point, we can make like simple references for procedures, okay? Do you need to ask me any questions?
Doctor, for our CNS examination, when we will do it?
Yes, please. CNS examination during this exam will also be very challenging. When you will be ready, and when you will come to the hospital?
Supposedly next Tuesday, but there are 5 students who will not be at the UIA.
5 from the whole batch?
And no, from our group, from this group.
This group who are 10?
Yes, out of 10.
So 5 is out?
Yes.
Oh Allah. And what about the other groups? How many?
The total number that will come is about 10 people only from this posting.
10 people, because year 3 there is 15. I think we should try to rearrange the groups. I don't know. I will see. We arranged already the groups for year 3. How is the batch? How many candidates you are? 20.
28.
28. 10 cannot attend. Okay, at that point, at least let us until that one of you who has a good video, he can work his video for them just to share us until we come to the final conclusion. Okay.
For this batch for pediatric, we have 28. However, those who can come to UIA only 10. So
10 only.
10 only out of 28.
Okay. I think this is a bit difficult, but there is some of them will come after a few days, or they cannot come at all.
No definite date yet.
Okay. We'll try to sort it, inshallah, in our next meeting. So you will get rapid reply about is there any new regulation for this point or not. For the CNS, then I think if 5 of you are not available, I need you to finish these procedures with a simple quiz, and we can go simply through the remaining. Just I will give you the important hints, and you just do a short presentation for the most important point, like everyone can read the indication, the contraindication, I will insist about the procedure itself. Okay. And then we need also to establish one time for CNS examination, because I realize that we need to be more competent with the nervous system. I think, inshallah, with the end of the next week, I should able to give you time. It may be a bit late, or during weekend. Let me plan and inform you. Okay.
Okay, doctor.
Okay. Is there any questions? So now only 10 can come this week to the UIA. Only 10.
Yes.
They are available already. They are present already on the camp. This 10
will come to UIA this Monday.
will come. Still, they will come on Monday. Okay. Okay, good, good. Let us see. Let us see. Okay, thank you.
And doctor, next week we have BST with you on Thursday.
You have what?
Bedside teaching on Thursday next week. Or developmental assessment.
Developmental assessment.
Yes.
Oh, it is bedside.
Yes.
Very good. Okay, so 5 of you will be available.
Yes.
What time is it?
10 a.m.
Okay, if there is no changes, no major changes, you can come the 5 and we can try to make video for them to attend with us. Let us see. I think there must be an important change soon. Okay, keep in touch, and I am ready for any help, inshallah. Okay.
Okay, doctor.
Okay. بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر وصلى الله وبارك على سيدنا محمد وعلى آله وصحبه وسلم. السلام عليكم ورحمة الله.
وعليكم السلام ورحمة الله.
Thank you.
Welcome.
Thank you, doctor.
Welcome.
Thank you, doctor.
السلام عليكم.
Thank you, doctor. Assalamualaikum.
السلام عليكم ورحمة الله.